Can you help me understand, like, practically speaking, how did you figure out how to load balance better? What were you measuring, and how did you do it?
Well, I'm not withholding anything here that everybody doesn't know. What we usually find when we go and look at hospitals that kind of tell the story is that you sit down and you watch workflow, okay, and you watch how they work and everything, and then you can see that almost in every case there's going to be times when the scanners are setting idle, or whatever the piece of equipment may be, and then you call up and you say, I'd like to schedule an outpatient exam. My doctor suggested I call the hospital. When can I get in? Well, that'll be 2 weeks. And you go, okay. And we go back and sit down, and we can do this for every modality. And this is only an example that we would set during that workflow analysis. We would see probably adding up, if you had 2 to 3 CT scanners, anywhere from maybe 2 to 3 hours during the day that those scanners weren't in use. They were just sitting idle. And you're calling and you're seeing this, well, why is it taking it 2 weeks for us to be able to schedule an exam? So you look at what's happening today. Most people are dealing with grease boards, and they're having, it's paper and grease boards. This is happening. Everybody has their own workflow that they do. And they try to they get the calls from the ED. I got 2 stat cases that have got to get in here, 1 trauma, 1 CT, or 1 stroke, got to get them in here. Okay, I got to balance that out. So what ends up happening, I'm not getting my outpatients through on their scheduled time, because somebody has to get bumped. Inpatients get pushed to the back of the day. If inpatients get pushed to the back of the day, how many of those were scheduled for AM discharges is always a good question. And then you look at the ED patients. Are you getting them from table time, from order to table time? What kind of time are we talking about? And these are critical issues, because in most hospitals you ask them, how's the interaction and the relationship between ED and radiology and the floors? Mm-hmm. Well, the floors will tell you, when the patient leaves here, I don't know where they are. I don't really know until they come back. Right? And then you look at... they're asking me to change the angle of the camera. Sorry. I'm supposed to stay incognito here.
That's right. That's what happens when we're live.
Right. So... we'll get very comfortable
That's
here.
Right. That's right.
So as I was saying, what happens on the floors, a lot of the nursing staff, they don't know where their patients are. Once they leave the department, it's kind of, okay, I don't know exactly where they are. And when you get to the ED department, you ask them, they have no idea what the status is with their patients when they've left the department and they're either in radiology. Only as an example, I still don't know what's going on. I don't know where they are. And outpatients, a lot of times, they're never communicated with. They may be sitting there for an hour and a half. So a lot of the things we try to address is to try to improve the order to table time for ED, most definitely. We try to make sure that the inpatients, there's visibility on what's going on with those patients, and that the nurses are involved, and they have visibility. And the beauty of all this is the transparency across the whole system for those who are all involved. And so the ED then knows what is going on, and that order to table time improvement improves that relationship, greater patient satisfaction, greater patient safety, no question. Same thing as on the inpatients. Instead of them going to the back of the day, you get more of them done prior to 12, improves the discharge rate. All of a sudden you have a savings, and that way, again, it's a patient satisfaction issue as much as anything. And then on the outpatients, again, it's patient satisfaction. I don't want to wait any more than 15 to 20 minutes past the time I'm scheduled to do this.
Great questions.
Okay, follow-up question from HIMSS Vista, asking if the increased efficiency relates to, is it the cost covered by the increased efficiency? Yes.
We're an annual subscription model, so we charge for an entire radiology suite, roughly $175,000 to $200,000, depending on the size of the hospital. And the answer to that is yes. We have seen another case study where they're realizing cumulative over 2 to 3 years, they had $500,000 plus just in CT for 2 CT scanners in revenue. The following year they had another 300,000, and the following year they had another. So they kept getting this cumulative effect over time that they were realizing, and they had absolutely no change in their shift hours. Their backlog went from 2 weeks to 0, and they went to, they had same number of FTEs. So all of it was entirely productivity gain.
Great, great. Other questions or feedback at this point? Great, great. Well, I guess kind of in our closing moments here. So for people who who are really not really familiar with Allocade and what you guys are doing, why should hospitals consider Allocade as their solution?
Well, nobody really is doing what we do, and everybody's kind of playing in the periphery, and that's why we don't really compete with anybody. The beauty of it is that we can take any database, and if you can build a model around it, then we can have it be actionable for you. We are not, virtually everything else that's in the market is static information. We're dynamic. We check for changes every heartbeat, and it updates itself every heartbeat. So you're getting everything right on time. And the beauty of it is that why would they want us? Again, nobody's doing what we're doing. And if you look at the situation today and you ask, are we getting maximum utilization out of our resources? That's not only equipment, but our people, which all tied to this as well. The answer probably almost everybody would say no. Am I really, really busy? Almost all of them would say yes. That's two different things. Efficiency gains will give you that greater utilization and greater capacity. And if you look at what is being proposed in our healthcare reform, when you're going to add another X million lives to the system, you're going to have to do, what you're going to have to do is more with less. So you're going to have these productivity gains. So that's my answer. And we are the only ones that can and are addressing it at this time.
Great, great. So for people who are here on site at HIMSS, where can people find you here? And for people who aren't here, where can they find you on the internet?
The internet is www.allocade.com, ALLOCADE.com. And here at HIMSS, we're in booth 7666.
Great, great. So this is Rick Smith, President and CEO of Allocade. Thank you so much for the time. I appreciate it.
Thank you, Mike. I appreciate it as well.
Okay, great. And Better Health coverage here at HIMSS 10 will be continuing in a few moments. We'll be right back.